So, good evening, everyone. A multi-center European study reported that compared to general population, patients with the moderate to severe ulcerative colitis have increased morbidity, poor health, deteriorated quality of life, and severe impairment of the social and professional activities. Simultaneously, 40% of patients with ulcerative colitis remain primary or secondary non-responder to conventional therapies. At MSN Lab, we believe every life matters and everyone deserves the quality medicines. Apart from the affordability and accessibility, we want to be the first to touch the human life. We are at MSN serving the patients better today and tomorrow. MSN has one of the Asia's largest R&D center at Hyderabad. We are truly integrated pharma API and formulation company. We are pleased to welcome our esteemed panel today for discussion on challenges and newer approaches in the management of ulcerative colitis. We welcome Dr. J.R. Mahapatra, Dr. Tuhin Mitra, and Dr. V.K.Rai. Welcome, sir. Welcome to today's webinar. And everyone knows Dr. J.R. Mahapatra is having the 40 years experience. The number of the publication took place. He has participated in many national and international conferences, as well as he has participated in the research work. Simultaneously, Dr. V.K.Rai is from the Apollo Hospital. He is very, he has done a lot of work in the hepatobiliary therapy of the gastroenterology. And Dr. Tuhin Mitra, we also welcome him. He is the DM Gastro from the Fortis Hospital, Kolkata. So we welcome all the panelists, and I request Dr. J.R. Mahapatra to take over the session and start the first presentation, followed by the Dr. V.K.Rai, and then we will have the two cases presentation by Dr. Tuhin Mitra as well as the Dr. Prabhat. Over to Sir Dr. Mahapatra.
Good evening to all my colleagues, and I am really grateful to MSN Lab who has done such an academic endeavor so that this reaches to the general doctors and physicians and gastroenterologists. This molecule, these are small molecule, what we call the small molecule, because this is the only orally active molecule which is not like vedolizumab or others which are injectable forms. But this is really good because it's absolutely less side effect. So Dr. V.K.Rai will be discussing about this, but I will just discuss about briefly about what are the ulcerative colitis drugs which are used. Just briefly, I will mention that. Before that, I will start sharing my slides so that it will be easier for me. Are my slides visible?
Yeah. Yeah.
Okay. Yes, so this is basically the how this tofacitinib works, that JAK-STAT signaling pathway and pathogenesis. I'll just briefly touch upon those pathophysiology, and this will incorporate evidence. There are so many trials for JAK-STAT inhibitors used, like Octave 1, 2, Octave 10. These are the trials. I will be discussing that, or if there is no problem, we can talk about that at the discussion point. So this is the diagram which I will be showing you at the end, because just to see to the left of this, you can see this to the left is that how this innate immunity comes. If there is a mucosal membrane is intact, as in healthy state, how the angiodymer, this mucosal epithelium and the mucin layer, how this is protected. Once in digitization, that this tight junction is disrupted, how this inflammatory cells they work, I'll tell in the subsequent slide. This is the normal end or healthy state, this is the disease state. And this is where this inflammatory mass, where this innate lymphoid cell, where the JAK-STAT inhibitors work. This is interleukin-13 mediated, Th1 and inflammatory macrophages. This is how this JAK-STAT inhibitors work. I'll discuss subsequently when I'll talk one by one. this is the animal model of IBD. If you understand this diagram per se, then you have understood how all the molecules, the newer molecules work in IBD. So basically, as you know, briefly touch on what is ulcerative colitis. It is an autoimmune relapse-remitting chronic disease of large intestine in which lining of the colon becomes inflamed and develops into tiny ulcers or sores. It has a chronic inflammation of the large intestine, further triggers the symptom of ulcerative colitis like recurrent diarrhea, abdominal pain, cramping, fatigue, weight loss, blood in stool, and intestinal blockage, sometimes sores or ulcer. As I already mentioned, prevalence rate of UC is 44 per 1 lakh population. Look at this, how this pictorial representation, this is for the general, this is how the normal colon looks when there is ulceration, loss of vascularity, edema, erythema, ulceration, how this in ulcerative colitis, it looks on a colonoscopic view. So what are the factors which causes it? You must know that there is some genetic susceptibility, and specifically it is very relevant with Crohn's disease. Environmental factor, again, Crohn's disease has got very relevance as compared to ulcerative colitis. And immunological factor, how the immunology works and how the drug metabolism has a relation to the immunology. This can be a topic for discussion. It will take 1 hour. What are the immunological factors? The environment factor like bad eating habit, like junk food, spicy, or lack of fiber in the food, poor lifestyle. Genetic factor like gene mutation or chromosomal damage changes in some drug metabolism. Immunological factors such as autoimmune disease, which because maybe reduced gut flora. The flora acts as a symbiosis. If there is a problem with the gut flora, it's called dysbiotic change. It could be mild, moderate, severe. Rectal bleeding with less than 4 bowel is mild. Rectal bleeding with more than 4 to 6 bowel motion is moderate. Rectal bleeding is more than 6 bowel motions with a systemic illness, or if hypoalbuminemia is there, less than 30 gram per liter, it's called severe. So in mild, initial damage of the mucosal layer of the large intestine. In moderate to severe, there is increased cytokine levels due to tissue damage and recruitment of immune cells, which result in inflammation and further tissue damage. This is important. Increased cytokine level due to tissue damage. Exaggerated cytokines which trigger further overstimulation. Cytokines will again stimulate the immune cells, leading to chronic inflammation with ulceration across the linings. So complication could be acute like toxic megacolon. These are the indication for surgery. Toxic megacolon perforation and hemorrhage. Here we don't some form of hemorrhage, mild form of hemorrhage, you can start with intravenous treatment, but in severe hemorrhage, there can be consideration for surgery. What are the chronic complications? Long-time ulcerative colitis can lead to cancer. Usually, these are the multicentric because of the dysplasia sequence, extra elementary manifestation like skin, erythema multiforme, and pyoderma gangrenosum, eye problems, and liver diseases could be there. So coming to the pathogenesis, under physiological condition, homeostasis normally exists between the commensal gut flora, epithelial cells that line the interior of the intestine, and the immune cells within the tissue. There I had a gross picture, but individually I am separating out now. This is the normal microbiota. This is the commensal microbiota. This is the anti-inflammatory bacteria, and these are the red ones are the pathogens. How the pathogens trigger this damage? Because there is an unstirred and this is the lumen, and this pathogen has to access this. Unless there is a damage to the epithelium or a damage to the tight junction, they cannot access to this. So if there is a epithelial barrier is disrupted, normally there is a IgA and mucous membrane protective tissue is there, and in the lamina propria there is like T helper cells, barrier function regulatory 3 gamma, interleukin 10 regulatory lymphocytes, and they help in physiology of inflammation or pathological inflammation. If there is physiological, it's called homeostasis. If there is pathological, it's called a disease state. So it can start from the intestinal lumen to mucous layer, epithelial barrier problem, or lamina propria problem. All these mechanisms, this lamina propria is the site where all these newer molecules work. Anti-integrins and JAK inhibitors work. So this homeostasis is disrupted in susceptible host by specific environment like diet, antibiotics, stress, genetic factor, resulting in hyperactivation of the T helper and T helper 17 type of cells, increase in tight junction permeability. This you can see the tight junction, and if there is increased permeability, because this is the tight junction which is tight, but this is the increased permeability there where the microbiome has already gone inside this lamina propria. So once that is in the lamina propria, that causes chronic inflammation and ulcerative colitis. You can see host genetic factor already I have mentioned that host genetic influence like NOD2, ATG, IL-23R, CARD9, and environmental factor like diet, antibiotic, and stress. So already three things are operating: autoimmune, host genetic factor, and environmental factor. So involvement of dysfunctional response from the innate to adaptive immune system. Multiple inflammatory cytokines are overexpressed. Amplification of immune response lead to phenotypic expression of the disease, mediated dysfunctional cell-cell interaction in innate adaptive immune response pathway. Look at this. This is the epithelial barrier. This is the microbiota that has come into that the tight function is disrupted. And this is the dendritic cell with pseudopods, and mucosal immune system is activated, and the recirculation of the inflammatory like pro-inflammatory cytokines are there. So this how it works from the endothelium. What is that adhesin, anti-integrins and things? This will be talked about when I will be talking about this slide proper. So look at this. This is the activated dendrite cell, and macrophages and activated dendrite cell. Once they are activated, that the T helper cell, and this is that the naive T cells which are activated by activated dendritic cells, and they in turn give rise to interleukin 4 natural killer cell, and T regulatory cells are good cells. They try to help, they try to suppress the inflammation. Most important is look at this colonic lumen. This is the mucous layer, and this is the mucin. If it is depleted, if the mucin is depleted from here, look at this, how these junctions and the mucus is covering with the epithelial layer causes increased permeability of the intestinal epithelium, resulting in increased uptake of luminal antigens. So if the mucin layer is also a problem, there is a commensal microbiota change to pathogenic microbiota, and the tight junction is a problem. All these cause to activation of the dendritic cells, and the activation of the macrophages causes processing of microbial like TNF alpha. So all the molecules, anti-TNF agents, anti-interleukin molecules, anti-leukin agents are acting here. And similarly, we have cells, how this is there. One thing one should, what is the MADCAM? This is from the typical specific intestinal endothelium. And ICAM1 is in endothelium of everywhere in the inflammatory area. But if you look at the MADCAM, this is very specific to the endothelium of the intestine. So from the system circular, they help in prevention of lymphocyte trafficking. So if there is a lymphocytic trafficking, then this lymphocyte will not further aggravate. And if there is a problem with apoptosis causes programmed cell death. If someone is preventing this apoptosis, like upregulation of inflammatory thermokines leading to recruitment of circulating leukocytes, which perpetuates the cycle of inflammation. This is important. Upregulation of inflammatory cytokines. This circulating T cells bearing integrin alpha 4 beta 7 bind to colonic endothelial cells of the microvasculature. So the addressing cells, adhesion molecule 1, whose expression is enhanced in the inflamed intestine, leading to increased entity of gut-specific T cells into the lamina propria. So from the endothelium, these lymphocytes go into lamina propria, causing further inflammation. So if someone can prevent this trafficking of the lymphocytes, then that will be useful in patients with ulcerative colitis. So again, this is the photograph which I had shown there. Look at this. This is the IgA dimer, immunoglobulin A dimer, which is acting in the epithelium. This is lying in the mucin layer, below the mucin layer. This is the IgA dimer. This prevents the microbiomes to here. And here is the Paneth cell. Paneth cell, this is the mature dendritic cell. This is the gut homing T cells. And look at this. Once there is inflammation, interleukin 23, interleukin 12. All these are inflammatory cells. And the T helper cell, T regulatory cells are benign cells. They try to control the inflammation. And autophagogens, they control by ingesting bacteria. And this. Look at this innate lymphoid. These blue ones, these are the innate lymphoid. This is important. Why innate lymphoid important? Innate lymphoid cells contain the JAK-STAT pathway. And interleukin 3, they are mediated through interleukin 13 and TNF-alpha. T helper cell and inflammatory macrophages can cause TNF-alpha, and TNF-alpha can aggravate or stimulate these innate lymphoid cells. Once innate lymphoid cells from the lymphatics migrate from there, that can cause further inflammation. So treatment goals is basically induction of remission, maintenance of remission, prevention of complication. So therapy-related allergy, intolerance, infection, lymphoma, one should know what causes lymphoma, and steroid side effect. Just briefly, I'll touch one by one. This is the classification of ulcerative colitis drug. I just mentioned the name because time is very short. Aminosalicylates is the common A, which is from Azad Khan. It started aminosalicylate. When it was associated with the sulfasalazine was the molecule, azo-reductase of the colon breaks down to sulfa and 5-aminosalicylate. 5-aminosalicylate is the active moiety. And corticosteroids subsequent, then immunosuppressant like azathioprine, methotrexate, antimicrobial like metronidazole and ciprofloxacillin, TNF-alpha inhibitor which is commonly used are infliximab or adalimumab. There are so many trials like Act 1, Act 2 trial, adalimumab Ultra 1 and Ultra 2 trial. JAK inhibitors like uracetinib, baricitinib and tofacitinib. What we will be discussing today about tofacitinib, the Octave 1, Octave 2 and Octave sustain trial. And finally, if they don't respond, you can go for surgery. So this is a medical treatment. This is a 5-ASA. There are 2 approaches, step up and top down approach. So 5-ASA, corticosteroid, thiopurine, cyclosporine, biologicals. So this is how it's sulfasalazine work. I have already bacterial azo-reductase breaks it to sulfapyridine and 5-aminosalicylate. There is no therapeutic action of sulfapyridine, but action is 5-aminosalicylate. All the side effects are because of the sulfapyridine. Corticosteroids used in acute treatment, they are longer acting like budesonide 9 mg, MMX technology. It acts, it disperses in colon, it can be used. And rectal administered for the topical use can be used. Thiopurine is effective for maintenance of remission. And dose already mentioned 2 to 2.5 here. 6 mercapto is 1 to 1. Azathioprine is converted to 6 mercaptopurine in the body, so to be active in the healthy state. So cyclosporine used to treat hospitalized patients because it's the intravenous preparation 2 to 4 mg per kg. Side effects are nephrotoxicity, opportunistic infection and seizures. Biologic like anti-TNF and IgG monoclonal antibody directed against TNF. It is the less toxic alternative to cyclosporine for patients with severe steroid refractory disease. Effective for both induction and maintenance of remission. Preparation usually we use infliximab, induction of remission by 5 mg per kg IV at week 0 to 6, and maintenance is 5 mg per kg every 8 weeks. Every 2 months we give them. We start with induction with very quick every 2 weeks, then 6 weeks, and every 8 weeks you are giving this. So this is end of my slide. I intentionally didn't touch upon the newer molecules and tofacitinib in this because Dr. Rai will be talking about that. So with this, I must thank you. There are so many trials I didn't discuss today. I'll thank you for your present hearing. If there are any questions, I'll take at the end. We'll discuss. I'll stop sharing so that I'll give chance to Dr. Rai to give his lecture. Okay, Dr. Rai. So I have stopped sharing. Vijay, you can go ahead with your presentation so that.
Okay, it was a very nice presentation, sir. It was exhaustive and it was in very detailed manner. And yes, we need to put our minds on this slide that you have shown in the first diagram. So that clearly shows everything. So most of my job is done because you have very nicely explained how the pathogenesis of IBD happens, how the barrier function get destroyed, and how these innate and adaptive immune cells, they get activated, and there's a dysregulation, disbalance between these two cells, and finally leading to the release of various cytokines that cause further damage in the barrier function and in the pathogenesis. So how this mechanism is taken up by the pharma company, and they have made one drug which can work on this mechanism and give the beneficial effect. So I am starting my presentation. So as already explained by Mahapatra sir, that there is a various genetic factor and environmental factor that cause damage to the mucosa, and that leads to release of cytokines, cytokine receptor activation, and finally leads to the JAK-STAT signal transduction. So JAK-STAT signal is the final pathway where the cells, they are activated and they release various cytokines by protein synthesis. So why we are targeting JAK-STAT signaling? There are many pathways. Why we are not targeting those? Why we are targeting JAK-STAT signaling? So JAKs actually play a role in regulating cellular proliferation, differentiation, and immune cell functions. So T cells, they are involved in the proliferation of these cells and final release of all these inflammatory cytokines. So JAK-STAT is the major signaling cascade downstream from cytokine and growth factors. So JAK family consists of JAK1, JAK2, and JAK3. And there's a STAT family which has 7 transcription factors. So JAK serve to transduce signal from cytokine receptor. So when the cytokine, they act on the T cells, then JAK pathway get activated, and that leads to release of cytokines. So JAK inhibitors interfere with JAK-STAT signaling. They compete with ATP for binding of the kinase domain of JAKs and inhibit JAK1, JAK2, JAK3. So JAK inhibitors are used effectively in other chronic inflammatory conditions like RA and psoriasis. They have widely used, and that's why this company, they have got this idea that why not use in the IBD. So JAK inhibition is a potential therapeutic target in ulcerative colitis because JAK1 and JAK3 is involved in transduction process of IL-2R and IL-6R receptors. So, and this molecule, tofacitinib, is basically a partial inhibitor of JAK1 and JAK3. It is not a complete inhibitor. It's just a partial inhibitor of JAK1 and JAK3. So JAK signaling pathways you see in ulcerative colitis, that here you can say all these interleukins, IL-2, IL-7, IL-10, interferon gamma, then IL-6, IL-12, they all act through the JAK-STAT pathway. And this JAK-STAT pathway, it activates the nuclear mechanism to synthesize more protein, and that's why they release various cytokines. So this tofacitinib, they acts on JAK2 and JAK3, JAK1, JAKs, they do not act on other, and that leads to the inhibition of this JAK-STAT signaling. So treatment goals, again, our treatment goals for the patient of ulcerative colitis is first is to control, that is induce the remission, and second is to maintain that remission. That is the goal. That is the basic of treatment of ulcerative colitis. This slide already explained by Mahapatra sir that what are the therapeutic options we have today. And in this armamentarium, we have added this JAK inhibitors. At present, it is basically approved for the treatment in ulcerative colitis, but the Crohn's disease data are coming up. They are not still available with us, but the ulcerative colitis, it is now approved. So if you see the current treatment option, is we start our treatment from mild, then moderate in severe disease. Depending upon the severity, we choose the drug. But the problem is that So why we are looking for JAK inhibitors? JAK inhibitors because whatever the current treatment we are giving, there is a problem because only 25 to 40% patients, this group of patients, they remain primary or secondary non-responder to conventional therapy. Even after giving the best therapy, they are keep on relapsing. They are, some are steroid dependent, even they are on azathioprine, even on these biologicals. There is a quite significant proportion of the patients who are not responding, and it is around 20. And we are facing day to day, every gastroenterologist is facing the problem that our treatment is very much limited. We are not happy with the kind of molecules currently we are having. They are not meeting the need. They are not, they are not giving good quality of life to the patients. So there is a gap. There is a gap for the therapy, and that's why research is going on to find out what are the other options where we can add in the treatment of ulcerative colitis, and one of these is the JAK inhibitors. So JAK kinase inhibitor C, that is tofacitinib, is a JAK inhibitor. It binds to the JAK enzyme and thus downregulates the production of pro-inflammatory cytokine and thus reduces inflammation. It is used, the beauty of this molecule is that it can be used not only for induction but also for the maintenance, just like mesalamine. And it is not like a steroid where we cannot use for remission. It is not like azathioprine where we cannot use for induction. So that's why in May 2018, for moderate to severe UC patients who have failed to conventional therapy. So nowadays, it is not the first line drug. This is approved only in those patients who are failed to conventional treatment, right? Like steroids, like mesalamine preparations, azathioprine. All these are failed. In those patients only, it is currently recommended. And in that group also, only the moderate to severe ulcerative colitis. Why? Why? Because the design of the study was like this. But because for the ethical clearance, you need to plan the study where you see that there is a gap, treatment gap. So that's why this group is selected. But as soon as we get more data on this, we will see that some studies are also looking into the mild cases also, or the initial treatment also. But right now, because of the ethical reason, because of the design of the study, it is only for the moderate to severe ulcerative colitis patients. The beauty is that it's a very fast acting and it's a short half-life, very short half-life, and that's why it's ideal for dose testing. There are good trials on this, and they have in one trial they have assessed, that is 598 patients in Octave 1 induction trial, and Octave 2 induction trial they have included 541 patients. And these patients are those patients who had treatment failure with conventional therapy. They were randomized to 4:1 ratio, and dose was 10 milligram twice daily or placebo for 8 weeks. And they observed the patient at 8 weeks, and there is an improvement in the appearance of lining of their colon at 8 weeks. What extent we will see. So they found that at 8 weeks, 18% of patients taking 10 milligram of tofacitinib twice daily achieved remissions, compared to 6% taking placebo. Similarly, at 2 weeks, tofacitinib, 30% of patients taking 10 milligram tofacitinib twice daily had improvement in the intestinal lining, and 14% in placebo. So you will be surprised that just 18%, only 18% patients, they have achieved remission. Only 13% patients, they have improved. Such a low, but actually it is not low, because we are treating moderate to severe ulcerative colitis patients who are already failed on other therapy. So this figure is encouraging. It is not disappointing. So if you see the clinical response overall, at 8 weeks is 58%. It's not achieved, we have not achieved clinical remission, but there is a response at 58 weeks. So for maintenance therapy, Octave Sustain 2 trial, they have found that 34.3% patients who are on 5 milligram and 40.6% they are on 10 milligram, they maintain the remission at 1 year. So it's quite encouraging data that 1/3 of the patient, they are maintaining the steroid-free remission, which is quite good, quite encouraging. So overall, if you see that this molecule definitely has future, and I'm hopeful that when other few more, we are also waiting for the few data, but right now this we have something to offer these patients who are not responding to our conventional therapy. So thank you very much for your kind attention. I close my presentation on this, and we will take the question at the end of the presentation. Thank you very much. And this is my center. We have started a new center, Live Gastro Center at Beggarhata. I invite all of you to please come to the center and have a look on that. Thank you very much.
Thank you, Vijay, for excellent presentation. And I think next we will have the case presentation before going to the discussion, or
yes, sir. We will have the case presentation from Dr. Mitra, sir.
Okay. So, Dr. Mitra, Tuhin, you could present your case so that I will have a discussion at the end.
Are my slides visible? Good evening, everyone. Are my slides visible?
Yes, sir. It is quite visible.
Okay. I want to congratulate Vijay sir and Mahapatra sir for their wonderful deliberations and very detailed deliberation, and Mahapatra sir enumerating the various pathogenic steps for ulcerative colitis, and Vijay sir elaborating how this new molecule can help us in treating refractory cases. So since the molecule is new in the market, our experience has been limited to few patients only. And I would like to describe one such patient who came to our setup. A 29-year-old woman without any significant past medical history was admitted to the emergency with 7-week history of mild colicky pain abdomen, bloody stool 6 to 8 times per day, and in the last 4 weeks, she gradually developed rectal tenesmus and lost 2 kgs. On examination, she had fever around 101 degree centigrade of Fahrenheit. Pulse rate was 104 per minute. Per abdominal examination was normal. Investigation revealed anemia with hemoglobin of 8.6. CRP was 67 milligram per deciliter. Fecal calprotectin was high in the range of 1975 microgram per gram. And stool cultures, cytomegalovirus, Clostridium toxin test were negative. So endoscopic assessment showed confluent deep ulcers up to mid-transverse colon with complete loss of vascular pattern. The endoscopic severity index was around 6/8. Barren classification was 2. And since the disease was beyond the splenic flexure, we described it as E3 disease. The histological analysis revealed crypt distortion with cryptitis and crypt abscess with lymphocytic and neutrophilic infiltration. So it was defined ulcerative colitis with severe activity. So the patient was diagnosed as severe ulcerative colitis and was started on intravenous steroids, that is hydrocortisone 100 milligram IV 6 hourly, along with other supportive measures. But by the 5th day of hospitalization, the patient, though apyaretic and painless, maintained 6 to 7 blood stools and her ESR and CRP was high and heart rate was high. So according to the True Loves and Wits index, she still fitted the severe criteria. So therefore, in case of non-refractory to refractory to steroid, we started the patient on infliximab. Infliximab 5 milligram per kg per day was induction dose were given with infusion on 0, 2, and 6 weeks. After patient 15 days, the patient was free of rectal tenesmus and achieved a partial Mayo score of 2. By 9, C-reactive protein was decreased to 4.7 milligram per liter, and fecal calprotectin was also decreased from an index episode of 1900 to now 412. So we kept the patient on infliximab. She was kept on 5 milligram per kg IV infusions. But 8 months after starting infliximab, the patient again had a relapse of symptoms. She began to have flare up of bowel symptoms in the form of bloody diarrhea. So we did an infliximab levels. The trough levels were around 3.1, which were low. So it was decided that infliximab dose should be maximized, and we maximized to 10 milligram per kg per day schedule for the 6 to 8 weeks. But again, 4 months later, the infliximab levels came out to be around 8.9, which was around satisfactory level of trough, and the patient was in clinical and endoscopic remission. 6 months after this episode, the patient was asked to follow up routinely, but she asked for an earlier medical appointment, reported abdominal cramping, had 5 to 6 blood streak episodes with loose stools, and the blood analysis revealed again a CRP of 17. Fecal calprotectin was raised, which was below 100. It has again raised to 1328, and this time the infliximab levels were not low. And we also did the antibody for infliximab, which was not high. So the trough levels were adequate, and antibody level was not high. So we decided to go ahead with an endoscopy, which again showed continuous colonic inflammation with marked erythema, absent vascular pattern, flyability, erosions, ulcerations, corresponding to UCEIS of 6/8. So in this context, it was decided to stop infliximab and start the patient on tofacitinib 10 milligram twice daily. Since, as Sir Dr. Vijay elaborated, and Dr. Mahapatra also, that this molecule has a very rapid onset of action. Trials have shown that it can act as fast as 3 days of the initiation of treatment. So this patient also showed good response. 6 days after the treatment, the patient was free from pain and had only 3 bowel movements, but it was without blood. The fecal calprotectin decreased to 195 microgram per gram of stool. Yes. So the induction with tofacitinib went uneventful. There was slight and transitory changes in the lipid profile. The total cholesterol and triglyceride in the range of 219 and 183 4 weeks after treatment start, and no other relevant analytical changes were observed. After 8 weeks, the patient was in clinical, endoscopic, and histological remission. For the past 4 months, the patient has been receiving tofacitinib 5 milligram twice daily for maintenance and remains free of symptoms and endoscopic activity. Thank you. I would take the questions after end of all the presentations.
Okay, thank you, Tuhin. I think our fourth speaker, has he already joined? Or?
No, sir. No, sir, he couldn't join. He was traveling, so he couldn't join.
Okay. So,
Dr. Mitra, can we stop sharing, please?
Okay.
Yeah, stop sharing. Yes. Okay. Vijay, could you switch on your camera? We can't see you now. So we'll have our discussion. We have got some questions. Mr. Deepak, have you got some questions so that we'll answer them, or we'll have our discussion amongst ourselves? I think the most common side effect with the tofacitinib, what they claim is the infection, like herpes zoster infection. apart from lipid profile change. And as you know, this is a oral small molecule, and it is absolutely other side effects are minimal, bare minimum side effects. So how often we find this infection to the panelist, we can ask, we find this infection like herpes zoster in these patients. You don't have to do hepatitis B, C, and HIV testing, etc., tuberculosis testing, what you do with infliximab. We don't have to do this thing, but the only infection that comes to mind is herpes zoster infection. Okay, Tuhin, you want to answer something?
Yes, sir. The experience from tofacitinib we can take the evidence what we have from the studies in rheumatoid arthritis. The longest study with tofacitinib, what I went through, was around 9.5 years, 9.5 years in rheumatoid arthritis patient. So there, the most common side effect was infections only. That was around 9%, and 11% of the patient had reactivation of herpes zosters. Around 11% of the entire population. It had around 1,100 patients followed for 9.5 years. Multi-center study in rheumatoid arthritis. So around 9 to 11% patient can have herpes zoster reactivation, sir.
Thank you. So there are some set of questions already we have been asked by the MSN group to answer this question. They think that they are really very aggressive in bringing of new products to this medical gastroenterology armamentarium, and this tofacitinib was new to us from them only. So they ask, can tofacitinib be combined with melsalamine or conventional treatment? I think Vijay, you want to answer that, or I think there is no harm in adding melsalamine to tofacitinib. There is no, because the mechanism of action is entirely different. One is acting on the mucosal epithelium proper. It is between subepithelial lymphoid tissue and JAK inhibitor pathway. So you can combine that. For maintenance treatment, you can combine melsalamine with this. So can it be given in Crohn's disease? I think we can't. We have lost the audio of Vijay actually. I think Tuhin, you want to answer that, or should I answer that?
Yes, you go ahead, sir.
Okay, because the trials so far for the Crohn's disease, this has not been used very much in Crohn's disease, but it has been few cases have been studied in the Crohn's disease. Because the trials what Vijay has mentioned, which Octave 1 and Octave 2 and Octave Sustain, these are for, one is for maintenance, one is for induction for moderate to severe ulcerative colitis. But for a Crohn's disease, directly there is no such study that to work that, but it has been one or two reports that it is still working this, because this is the only oral form which is available, because all other forms like adalimumab is subcutaneous injection, infliximab is intravenous injection, and there is a lot of complications and problems with that. So this is still useful, but the use is not as compared to ulcerative colitis. So should I say, what are the dosage regime of tofacitinib? Already Vijay has already mentioned, and Dr. Tuhin has clearly mentioned in each patient that 10 milligram twice daily as the induction dose. And once you have this maintenance, you have the induction of remission, you can go for 5 milligram twice daily as maintenance dose. And your tablets are available with 5 milligram, isn't it, Deepak?
Sir, it's available in both 5 milligram and 10 milligram. And recently, the first time in India, MSN has introduced tofa dose 10 milligram in India at the fraction of the international prices.
That will be very useful, because to start with just one tablet twice daily instead of 2 tablets twice daily, we can use 10 milligram tablet of tofa dose twice daily. So looking at an evidence on efficacy, can we use tofacitinib as first line in NAV moderate to severe ulcerative colitis patients? And they think that because this is our hesitancy to start tofacitinib in first place, looking at the price, could you tell what is the price of 10 milligram tablet? Because it will be expensive as compared
Sir,
to the cost.
It is available at the 70 rupees per tablet, 10 milligrams.
Yeah, the thing is that just to start with a NAV patient, will be reluctant to start in a NAV patient. If someone has problem with steroid refractory or someone has taken infliximab, has come with problem, we use as a second line of drug, not as a NAV patient as a first line of treatment.
Okay.
Do you agree with this or? Okay. So I'll go for the next question. What is has been asked for the panelists? So just I'll say. Why JAK-STAT pathway is important? Already Dr. Rai has mentioned JAK-STAT, how this signaling transduction molecule is important, because that has something to do with your innate immunity and lymphocytes. And if that is a problem there, because this is very specific subtype, it is not like lymphocyte trafficking or anti-integrins or anti-adhesives. So this has got different pathways. So this mechanism is quite important in the presence with ulcerative colitis, because this is typically acts in the mucosa. This is the lamina propria. This is very selective site of action. So that is the reason why it doesn't have the side effect what other drugs have got. So what is the role of tofacitinib, ideal candidate for tofacitinib? I think Dr. Tuhin had the ideal candidate of tofacitinib. What he had that patient had already taken this infliximab, and subsequently his calprotectin went up, and he lost to follow-up, and these are the candidates. You cannot, because look at the cost of this. If you want to use infliximab or adalimumab, they are very costly to maintain. Just 40 milligrams subcutaneous every 2 weeks for adalimumab and the infliximab to give such a higher dose as maintenance. It becomes very cumbersome. Not only cumbersome, they have to come to a hospital for this. And this tablet, you can easily use that oral form which is available easily. You can use that. They can take it at home. They don't have to come to the hospital. They just have to come for follow-up with this medicine. So this is very good. In my practice, I feel this is very useful as compared to infliximab and adalimumab to use as a maintenance.
Great, sir.
When should I see visible clinical response of tofacitinib? Because as Dr. Tuhin has already shown in his case, that the visible clinical response is that endoscopic remission is one, and biochemical remission and biochemical, that is endoscopic remission and clinical remission. The patient's frequency of diarrhea has come down, tenesmus has reduced, and endoscopically the mucosal healing has occurred, and biochemical the C-reactive protein and calprotectin has come down. These are the three parameters: clinical, biochemical, and endoscopic. And most important is histological remission, which is very difficult to achieve, because despite your mucosa looks normal, end up doing histology, you will find some crypt distortion, crypt branching and inflammation to persist in them. This is very difficult to achieve, but clinically, biochemically, endoscopically, you can achieve. Your aim is to look at these three parameters and to see if tofacitinib is useful in these patients. So, are there any more questions? No, we can have panels. So, Tuhin, you want to add anything or you want to mention anything? So, I can't see Vijay now. Vijay is, I think, I can't see Vijay.
I think sir, Dr. Ranjan has also joined us.
Prabhat Ranjan, okay, so.
Yes. Actually, I'm a bit late.
Okay. So, Prabhat, we have already discussed about the details about this, but if you want to have your case, we still have our time that you can present your case so that we can have discussion. Okay,
yes,
Mr. Gupta, if anything else you want to ask, we can answer that after this.
Yes,
yeah, no, sir. First, let's have the presentation of Dr. Ranjan, and I was having some questions from the patient point of view.
Okay, no problem. We'll answer that.
Yes.
So, desktop था वो कहाँ गया? कल वाला. इसमें शेयरिंग नहीं होगा फिर ये उस पे शेयरिंग होना चाहिए ना.
That green button, Dr. Ranjan, that the green button share option is there. A green arrow, upwards arrow.
Share.
Share screen. Yeah. That's fine. You can start sharing. Yeah. Make it full screen mode.
Yes.
Make it full screen.
आ गए.
Now you go to that that in the bottom, the fourth one, that screen is showing. That touch that will be full screen.
Yes.
Yeah.
Is it
that's
okay
fine.
now?
Yeah, it's okay.
Okay, yes, sir. Actually, the two breeders were come, so I am a bit late. Okay, let's start. My case is a 30-year-old male with history of IBD, ulcerative colitis, pancolitis, without any extra-intestinal manifestation. For initial 4 years, he was in clinical remission, but for last 1 year, he has repeated episodes of relapses, for which he sought multiple consultations with different gastroenterologists. He was started on multiple sessions of steroids, but he was poorly responsive to steroid. And about 3 months ago, he was started with adalimumab, which also failed to improve his symptoms. When patient came to me, he had stool frequency of 4 to 5 per day. He had occasional blood in his stool, no abdominal pain, there was no any fever. On his general examination, it was found patient has mild pallor. There was no icterus, no any edema, no lymphadenopathy. His weight was 54 kg and blood pressure was 128 by 84 millimeter of mercury. His pulse rate was 78 per minute. On his abdominal examination, there were no organomegaly. There was only mild tenderness in left lower quadrant. Other systemic examinations were unremarkable. His lab parameters were hemoglobin was a bit low. It was 10 gram per deciliter. RBC were microcytic and hypochromic. Differential counts were in the range. His platelet count was a bit on higher sided, and the CRP was also on higher side. And his renal function, thyroid function, normal. LFT shows only slight decrease in his serum albumin. Other transaminase and alkaline phosphatase were in the normal range. He was non-diabetic and viral markers were negative. Stool examination shows no ova, no parasites. Clostridium difficile toxin were evaluated and it was shown to be absent. His fecal calprotectin was significantly high, and on CT enterocolonography, no extraluminal pathology were there. Small bowel was completely normal, but in his large bowel, he has diffuse non-enhancing thickening in the rectosigmoid region. Colonoscopy was suggestive of normal ileum, cecum, and ascending colon, and below that, he has a moderate severe ulcerative colitis. Chest X-ray was normal, and Mantoux test was negative. At present, at that time, he was on Pentasa sachet, 2 gram twice a day, Budage OD tablet, 9 gram per day, tablet folic acid and tablet Selcal. The case was discussed with patient and his relatives, and they were agreed to start with the tofacitinib, and it was started in a dose of 10 milligram twice a day. And within a span of next 2 weeks, his stool frequency decreased to 3 to 4. No blood were evident after 3 weeks of treatment, and after 4 weeks, stool frequency came to 2 to 3 per day without any adverse effect. And after 8 weeks, stool frequency was 2 per day, and there was generalized well-being feeling of the patient. After 8 weeks, his stool frequency was 2 per day, no blood. Hemoglobin was improved, 13 gram per deciliter, WBC in the range, CRP came down to normal, fecal calprotectin came down to normal, albumin improved. That means patient is improving with the tofacitinib, and he was advised to continue the same medicine, but in a decreased dose. And in maintenance therapy, he was put on a dose of 5 milligram twice a day, and he was asked to visit after 2 months with complete blood count and CRP and LFT levels. And at present, patient is doing fine, and when he will come, next course will be discussed with the patient and his relatives. Now come to the further discussions.
Thank you, Dr. Prabhat. Basically, what we'll do is we'll take up some questions. And as you know, this was again a patient who had a failure of adalimumab. So this is a good candidate for tofacitinib. So Prabhat, Dr. Stop sharing your screen so that we can have your discussion. Okay. Mr. Gupta, I think already what he has mentioned that the first one is case of infliximab failure. This one was adalimumab failure. So these are two cases, very illustrious. Yeah, so if you have still some more questions, we would like to answer them.
Sir, may I ask you some questions from the patient's perspective, because I am not a doctor, but I would like to ask some questions from the patient point of view, sir, if you permit us, sir.
Definitely.
Yeah. Sir, what initial symptoms patient have for the ulcerative colitis, and when they should approach to the doctor?
I didn't get what you want to ask.
Actually, patient having
what initial symptoms patient is having, sir, and when a patient should approach to the doctor?
Okay. Okay. Yes. Patients with.
Yeah, you want to answer? Okay.
Yes.
Answer.
Yes. Okay. Patients with IBD usually present with multiple episodes of stool, and it may or may not be associated with the blood. There may be some mild pain or sometimes significant pain, but usually there is mild pain. And in a very few occasions, when patients have very severe presentation, they might present with significant pain, abdomen, vomiting, high-grade fever. But usual presentation is frequent stool that may or may not will be associated with blood.
I think, Mr. Gupta, there are two presentations. One is they have chronic diarrhea or chronic bowel problem, or there is the other form who has got acute problem, acute self-limiting colitis, which is very difficult to differentiate from ulcerative colitis acute presentation. So if they have got loose motion along with bleeding, it's very clear cut that it is AS acute colitis. If it is on histology, you find that the crypt distortion or crypt branching on endoscopic biopsy, then it tells that it is not acute only, there is a superimposed acute on a chronic inflammation. So presentation could be variable, could be acute presentation, could be chronic presentation. But Dr. Ranjan has already mentioned that it can be presentation without blood, it can be presentation with just bowel frequency, and usually the presentation is a chronic form, it's not acute.
Is ulcerative colitis is the curable disease?
There are three patterns of ulcerative colitis. Once they have got acute presentation, usually 40% of patients, they never come back with that presentation. They are completely cured. And there are other forms, there is a relapsing remitting form. They will come and go. There's an undulating type of pattern. And the third variety have a chronic continuous pattern. They will always have some degree of inflammation. Whatever you do, some degree of inflammation will persist. So very rarely they get clear of all their ulcerative colitis symptoms. So as I already mentioned, these three patterns are there. So which if your patient is good, lucky, then you can have the first type of presentation.
Great, sir. And sir, one more question I am having. What precaution these patients should take it in their day-to-day life when they detected with the ulcerative colitis? What they should eat, what they should not eat, or what, how they can be better feeling they can have?
Yeah, usually what we ask them to avoid high roughage diet. They think that the symptoms could be variable. Some patient who has got left-sided colitis, you may find stool persist in the right colon. They will have constipation. And if that is a problem, you have to use some treatment so that their stool frequency is increased. And if someone has got just selective rectal problem like tenesmus, and you can use anything, but usually we ask them to avoid milk product, because it has been seen that if you take a lot of milk, the symptoms aggravate that. Otherwise, there is no hard and fast rule which particular diet you have to take. You can take any type of diet depending on your symptoms.
I would like to add something more here. These patients are advised not to take frequent unnecessary use of antibiotics, because unnecessary and frequent use of antibiotics usually exacerbate their problem. And second thing, the painkiller. It is found that NSAID groups of painkiller are known to exacerbate their ulcerative colitis symptoms. So it's better to avoid the NSAID group of the painkillers rather than to use the simple paracetamol or tramadols. They usually do not exacerbate their symptoms.
I think Dr. Ranjan was not there in the initial thing. So that was the discussion. We told that two antibiotics which can be used there is metronidazole and ciprofloxacillin. So usually we tend to avoid because of the chance of superadded Clostridium difficile infection. And any patient with acute presentation, we always try to look for cytomegalovirus by taking biopsy, RT-PCR for rapid PCR test for cytomegalovirus. So infections we rule out, and if antibiotics have to be given, usually we try to give this type of antibiotic. Unnecessary, injudicious use of antibiotics is to be deferred in these patients.
And the last thing is the regular follow-ups.
Yeah.
These patients usually think after treatment of 3 months, suppose, or 6 months, their stools are okay, there is no blood, and they usually think that doctor is frequently calling me, they are making money from me. Why should I repeatedly go to that doctor? And this should not happen. There should be a clear education that it's a lifelong disease and regular follow-up is necessary.
Great, sir. So, sir, thank you very much, Dr. Mahapatra, Dr. Rai, Dr. Ranjan, and Dr. Mitra for the valuable insight. And we are very sure, sir, your presentation will help the hundreds of the doctors and the thousands of the patients for the better management of the ulcerative colitis in India. And I am proud to say that MSN is the first company in India who have made it available Tofadose 10, that is the tofacitinib, at the fraction of the international prices for the management of the ulcerative colitis in the mild to severe cases, sir. So once again, thank you. And sir, anything for us, please let us know, and we would like to connect with you and stay in touch with you for the further discussion and webinars on the ulcerative colitis and other gastroenterology topics for the general audience and doctors and publics. Thank you, sir. Thank you very much.
Okay, thank you, MSN
thank you, Mr.
team.
Gupta. It is really great here. It is giving us this platform to discuss about this new molecule, which is new to India and new to us also. So this is really great. Thank you very much. Thanks, everyone.
And this program has been released, sir, on the YouTube and Facebook, and we will share with you the recordings in the within 2-3 days. So you can share with your patients and other colleagues also over there.
Okay, thank you.
Thank you.
Thanks.
Thank you very much.
Okay. Good night to you all.
Okay,
Good night, sir. Good night.